Thank you very much for the kind introduction and for inviting me to give this presentation at your institution. So you've already introduced the topic, so I will talk about disinfectants and cleaning products and the association with respiratory health outcomes. So this might not be needed for today's audience, but I usually start with a brief introduction on asthma and COPD, which are the main chronic respiratory diseases and the two diseases I will talk about in this presentation. So asthma is a well-known chronic inflammatory disease of the airways, which is characterized by attacks of breathlessness with wheezing and chronic respiratory symptoms. And COPD is characterized by a progressive and largely non-reversible airway obstruction leading to airflow limitation and is usually diagnosed by lung function measurements. So these two diseases are common. So I'm showing here some figures for the prevalence in France, but I think it's quite close to what you have in the US. So the prevalence of asthma in children is 10 to 15%. In adults is around 6 to 10%. And for COPD, which is disease that appears later in life, the prevalence in adults over 45 years old is estimated to be 5 to 10%. It's diseases that are multifactorial and influenced by a large number of exposures throughout life. And of course, for asthma and COPD, we can think about air pollution and smoking, especially for COPD. But there are also other lifestyle-related risk factors, such as diet or BMI, occupational exposures, which will be focused on one part of this talk. And in recent years, the role of early life exposures have also been emphasized in both asthma and COPD. So if we look at exposures in adulthood, occupational exposures are responsible for a large part of adult asthma and COPD cases. It's been evaluated to be about 15% for both of these diseases. And beyond new cases of asthma and COPD caused by occupational exposures, this exposure can also be associated with aggravation and exacerbation of asthma and COPD in patients who already have the disease. So for asthma, there are a lot of agents that have already been identified to cause asthma at the workplace. It's evaluated to be around 500 agents, classified in large categories based on the mechanisms by which they can induce asthma. So two largest groups are sensitizers and irritants. But irritants induced asthma is less well understood, both in terms of etiology and mechanisms. For COPD, the literature has focused on large categories of agents, such as vapors, gases, dust, and fumes, and irritants in general. But a few specific agents have been identified, and it's also interesting to note that there is relatively few data on COPD related to occupational exposures in women. And in the last decades, there's been an increasing amount of research on the role of disinfectants and cleaning products in these diseases. So mainly first on asthma, but then more recently also on COPD. And so this is the outline of my talk. I will first discuss the findings from study on exposure to disinfectant and cleaning products and respiratory health in adults. And first discussing occupational exposures, but then presenting also some studies that focused on exposure to these products that we can experience in the context of domestic cleaning, so at home. And then I will present more recent findings on the role of exposure to disinfectant and cleaning products in respiratory health, also in children. So what are disinfectant and cleaning products? Well, that's quite frequent exposures at home, of course, but also in various workplaces. But there are some workplaces where the exposure is particularly high. For instance, healthcare settings due to the high need of disinfection in these settings. And disinfectant and cleaning products, it's a large group of chemicals and products that contain actually several ingredients. So I'm showing here some examples of the main products or chemicals that we can find in these products. Either some products that we can use at home, which are commonly used at home, but can also be used in other workplaces, in workplaces, I mean, such as bleach, ammonia, some acids, or quaternary ammonium compounds, or quats, which have been increasingly used, especially since the COVID crisis. And then some products that we can find more specifically in healthcare settings, such as aldehydes. So I'm giving here the example of formaldehyde, which is actually not used anymore as a disinfectant in healthcare setting, but was used as such in the past, and now is still used for tissue preservation. And glutaraldehyde. There are also a lot of use of hydrogen peroxide, which is often mixed with acids, such as peracetic acid or acetic acid. So these chemicals can be either irritants or sensitizers, and that's why they're relevant both for asthma and COPD. And exposure by inhalation occurs through the evaporation of volatile compound when the product is applied, but is increased, as we may expect, when the product is used in spray form. So the first studies that suggested that the use of these products might be a risk factor for asthma were studies in occupational settings. And first, based on reports from surveillance data, so from networks in different countries that report occupational asthma cases and look at the industries and jobs where these cases come from. And this surveillance network reported in several countries that cleaners and healthcare workers, there were high rates of occupational asthma cases in these industries and occupation. So at some point in the US, it was the first industry, and in France, the second industry for occupational asthma cases after bakers. And when there were more detailed data on the jobs involved, it was often hospital workers and mainly nurses, nursing aides, and cleaners in hospitals. And sometimes there were information on the causal agents, and we could see over the years that disinfectant and cleaning products were increasingly identified as causal agents. And then these findings were confirmed in many epidemiological studies that reported increased asthma risk, so either increased risk of asthma development or asthma symptoms, again, among nurses, nursing aides, and cleaners. So now the association between occupational exposure to disinfectant and cleaning products and asthma is well established. You can see in this meta-analysis published in 2020 that there are now quite a lot of studies, and this meta-analysis reported meta-relative risk of 1.50, so 50% increased risk of asthma associated with this kind of exposures. This has been again confirmed recently in large cohorts with more gold standard evaluation of occupational exposure to cleaning products using an occupational asthma specific job exposure matrix. So I'm showing here the result of two French studies, one from very large cohort of adults, one from the Nutrinet Santé cohort, and one from the Constance cohort, in which associations were found with current asthma in both cohorts and in both men and women, with increased asthma symptom score. And in the Nutrinet study, we also investigated association with poor asthma control, and we found a pretty strong association, especially for poorly controlled asthma. So it's now well established, as I said, that these products as a large group can be associated with asthma. But if we want to move to suggest strategy for prevention, we need to better identify which are the specific chemicals which are associated with asthma, because of course we cannot just stop cleaning and disinfection in general, especially, for instance, in healthcare settings. So I'm summarizing in this table the main studies that try to address this question. So which are the specific cleaning agents associated with asthma outcomes? And I sorted these studies according to the method used to evaluate occupational exposures. So first, the most studies actually just used simple questionnaires to evaluate exposure to specific cleaning agents, which can work well for some chemicals. So for instance, for bleach, which is easily recognizable and has a specific smell, workers are often aware of using bleach or not. But it can be more tricky for other chemicals. So if I give the example of quaternary ammonium compounds, it's chemicals which have very long, complicated name. If you look at the ingredient list, and not always mentioned on the ingredient list. So probably workers who use these products are not aware of using them. Which can cause underestimation of exposure if we just use a questionnaire to evaluate this exposure. Another issue with questionnaires is that we might have a differential misclassification error. So that would happen if, for instance, participants with asthma are more aware of the exposures, the products they use, or pay more attention to it. So we might have a differential report of exposures in people with and without asthma, which would cause bias in the estimates of the association with asthma. A few other studies used another method, which is called expert assessment. So it's a method where you just ask experts who are often hygienists or occupational physicians to evaluate exposure of the participants case by case, and based on the information collected on the job and on the tasks that are performed. So it's a good method in occupational epidemiology. The issue is that it's very long to implement and costly, so it's difficult to apply in large studies. So you can see that here two studies use this method, and it's feasible in studies of several hundreds of participants, but not for larger studies that may be needed to evaluate the impact of a large amount of chemicals on health. And so the last method that is very often used in occupational epidemiology is the use of job exposure matrices. which is also a gold standard, and it's easily applicable in large study because it's basically just a table that links, that provides an estimate of the level of exposure to different substance for each kind of job. So if you just collect information of the job, you can apply a job exposure matrix. And a more recent method that has been developed is to use, but which is similar, is to use a job task exposure matrix, where the evaluation is based not only on the job, but also on the task. And this kind of method provides more accurate estimates of the exposure. So I'm going to show you some example of the use of this method in the context of the Nurses' Health Study 2, which is a cohort I'm sure many of you know because it's a US-based cohort, very large longitudinal cohort of US female nurses. So in this cohort, we developed a job task exposure matrix to evaluate exposure to different chemicals that are contained in disinfectant and cleaning products. And we studied their association with several outcomes. So first, we looked at poor asthma control. And we found that exposure to several chemicals, so formaldehyde, glutaraldehyde, bleach, enzymatic cleaners, and hydrogen peroxide, were associated with poor asthma control in nurses with asthma. We then looked at asthma incidents based on longitudinal data collected in this cohort. And here we did not find an association between exposure to disinfectant and cleaning products and asthma incidents. But we thought that this might be due to a healthy worker effect, in particular because at the time we did this analysis in the cohort, the nurses were already at a late career stage. And it's possible that there was a health-based selection out of exposed job before that, earlier in their career. And we thought that it might explain the absence of association here. And this was supported by another study that we did a bit after, which was in the Nurses' Health Study 3, which is a similar cohort of nurses, but started a bit later. So it included younger nurses and nurses at earlier stage of their career. And in this cohort, we found that exposure to high-level disinfectants was associated with increased risk of asthma development. And finally, in the Nurses' Health Study 2, we thought that we would also examine COPD incidents, as many of these chemicals are actually irritants, so it's also relevant to examine their association with COPD. And we indeed found increased risk of COPD incidents associated with exposure to several of these products. So we still need more data on this question, in particular to identify the specific chemicals associated with poor respiratory health outcomes and more longitudinal studies. And for COPD, which has been investigated really more recently, we need additional studies, especially with lung function measurements to evaluate the presence of COPD and not just self-report. So that's what motivated the CONNAITRE project in the Constance cohort, which will aim to investigate these questions, the impact of occupational exposure to disinfectant and cleaning products on asthma and lung function in a very large French cohort. And in the context of this project, we collected detailed information on exposure to disinfectant and cleaning products in all participants who are in jobs potentially exposed to these products. So we included not only healthcare workers, but also cleaners and workers in the food and catering industry who are also highly exposed to these products. So here on the left, the questionnaire is in French, but basically it asks questions about the type of job, the type of cleaning and disinfection tasks, and the type of chemicals used at work. And we are currently working on methods to have a better assessment of occupational exposure. So we use this data to develop a job task exposure matrix in this population, using classification and regression trees to be able to account for a large number of jobs and tasks. And recently, we have also used clustering methods to identify occupational exposure patterns to take into account the multiplicity of exposures, since we're not exposed to these chemicals one by one, but we use products that contain several of these chemicals, so we have exposure to multiple products at the same time. So these are some findings from this analysis where we used clustering methods to identify occupational exposure patterns. So we identified 4 groups of workers. So that was only among healthcare workers, this analysis. So the first group was defined by mainly characterized by physicians and nurses who had a low exposure to disinfectant and cleaning products. The second group, including the mainly medical laboratory staff and medical technicians who were moderately exposed to common disinfectant and cleaning products. So that was, for instance, bleach or alcohol. The third group included mainly nursing assistants and nurses who were highly exposed to a few disinfectant and cleaning products, and actually it was mainly quaternary ammonium compounds. And the last group included nurses and nursing assistants highly exposed to multiple disinfectant and cleaning products, including high-level disinfectants. And when we looked at the association with asthma symptoms, we found that the second and third group had higher risk of asthma symptoms. And this was observed only in women. Surprisingly, we did not observe association for the fourth group, which included the most exposed participant. But again, this absence of association is possibly due to healthy worker effects. So now I'm going to show some findings on domestic exposures, because, of course, these exposures are not only present at the workplace, but in home, we all use these cleaning products. So, of course, researchers ask the question: do these exposure at home may they be also associated with respiratory outcomes? So the answer is yes. So I'm showing here one of the first study that has been conducted on domestic exposure to disinfectant and cleaning products. So that's a study conducted in the European Community Respiratory Health Survey, which is also a quite large cohort in Europe. And this study focused on the use of cleaning sprays and reported, so that's also a longitudinal study, and we can see very clearly on this figure that the use of at least 2 spray or 3 spray weekly was associated with increased risk of asthma development. So many studies focused on cleaning sprays, but others also looked at the use of irritant cleaning products. And here I'm showing the example of a study in France that looked at the use of irritant cleaning products, so which included ammonia, bleach, solvents, and acids. And the use of at least one irritant cleaning products weekly was modestly associated with increased risk of asthma, but you can see that the risk increased with the number of irritant cleaning products used every week. Another important study in this field is also based on the ECRHS, so the European Community Respiratory Health Survey, and looked at cleaning activities and lung function decline. So that's also a longitudinal study over 20 years of follow-up. And this study showed that not only working as occupational cleaner, but also cleaning activities at home was associated with increased FEV1 decline and FVC decline. And this was observed only in women. And more recently, other type of uses and products have been investigated. So, for instance, the use of wipes and of perfumed products, and also more recent use, such as the use of green products and homemade products that people may prefer, maybe thinking that it would be less harmful for respiratory health. And this has been investigated in two large cohorts. So again, the Constance cohort and the Nutrinet Santé cohort. And these use were investigated in association with asthma symptom score, but also taking into account the co-use of more traditional products such as irritant and sprays. So you can see that in the Constance cohort, for the use of wipes and of perfumed products, these uses were associated with increased risk of asthma symptom, regardless of the co-use of irritants and sprays. While for green and homemade products, the association was only significant when there was a co-use of irritant and spray, and not statistically significant when there was no co-use. So this data would suggest that indeed these products are less harmful for respiratory health. But unfortunately, this was not confirmed for green products in the Nutrinet Santé cohort, where associations were found with current asthma, even when there was no co-use of irritant and sprays. And associations were also found with poorly controlled asthma. And for green products, this has been further confirmed in a longitudinal analysis in the Nutrinet Santé cohort, looking at the evolution in the use of green products over 2 years, so between 2018 and 2020, and the association with the asthma symptom score in 2020. And you can see here that a persistent use or an increased use of green products was associated with a higher symptom score, while for a decreased use of green products, there was a tendency for an association with a lower number of asthma symptoms. And I will finish this talk with some findings about the impact of these exposures in children. So So this has been also investigated a bit more recently, but some that either maternal exposure to cleaning products during pregnancy or passive exposure of the children during the early years of life could be associated with respiratory symptoms. So now several studies have showed that these kind of exposures were associated with increased risk of wheezing in very young children. But studies that looked at asthma development in children are a bit more mixed, and it's difficult to conclude for now. But so that's for the exposure at home. But children may also experience high level of exposure in other places, and in particularly in daycares where there might be an more intense use of cleaning products and disinfectant to protect the children against the spread of infection. So that's something that we wanted to investigate in the context of the CRESPI study, which is a study we developed in Paris region. So we included in this study a bit more than 100 daycare centers and 551 children who attended these daycares. And we included them between 2019 and 2022. So in this cohort, we have very extensive characterization of exposure in the indoor environment. So we did indoor air quality measurement with active sampling of volatile organic compounds and aldehydes, collection of settle dust to also evaluate exposure to semi-volatile organic compounds, including biocides, a daycare questionnaire that asks about building characteristic, ventilation system, and other kind of characteristics. And we also used a smartphone application to scan the barcodes of all cleaning products used in the daycare and developed a database to link these barcodes with the ingredient list of these cleaning products. So these data were collected quite recently, so we're still analyzing many of these data, but one of the first findings was that exposure to high-level exposure to disinfectant and cleaning products in the daycare, which was based on a score that used the frequency and the number of products used, was associated with some wheezing outcomes in children. So in particular with everwheeze with use of inhaled corticosteroids, and suggested association with everwheeze and recurrent wheeze. So we have several ongoing projects in this cohort. We're currently looking at indoor air quality and wheezing outcome in children. We also want to use toxicological score, which is called the MENAGE score, that classifies the cleaning products based on the toxicological risk. And we have the hypothesis that products with a better grade for this score would be associated with fewer symptoms in children. And finally, we are also examining microbiome in dust and in nasal samples, and looking at the association between cleaning practices and other daycare characteristics and the microbiome. So to conclude about all these findings, there is now strong evidence to support a link between disinfectant and cleaning products exposure in asthma in adults, and some evidence in children as well. The evidence to support a link between disinfectant and cleaning product exposure and COPD is accumulating. But we still need to clarify the causative agents, and this is crucial knowledge if we want to develop and improve prevention strategies, in particular in healthcare settings. What we know now about potential strategy for asthma and COPD prevention, well, we can advise to limit the use of sprays, to use disinfectants only when it's necessary, and often in the context of home cleaning, it is not necessary, and it's feasible just to clean with quite simple products or techniques, such as just soap and water or microfiber cloths. It's always good to open the windows when cleaning, but also to improve building ventilation, especially in some workplaces. And regarding potential safer alternatives, well, we've seen that for green products, we need further evaluation. And probably this category of products include very heterogeneous products. And it's not because it has this green or ecological label that it's not harmful for health. And in healthcare settings, new methods for disinfection that are non-chemical methods, such as the use of heat or UV light, should be tested and implemented when possible. So I would like to acknowledge my colleagues in my teams, and especially students and postdoctoral fellows who performed many of the work for the study that I presented in this presentation. Colleagues at Harvard and at CSTB for the different cohorts I have presented. And of course, all the cohorts and participants of the cohorts on which this study were based. And thank you for your attention.